changing gears, and I know there were lectures before, and I give lectures on PCO. But the reason why I'm mentioning PCOS is that in our clinic, well, I'll mention this. We do TSH, prolactin, 2-hour glucose tolerance test. We look at the 2-hour glucose and insulin level, and to us, insulin resistance is a level of over 40. We 50 to 70% of our PCO patients tend to have insulin resistance, and most of them are obese. I no longer do the fasting ratio of glucose to insulin. We only do the 2-hour glucose tolerance test, and we're picking up a lot more insulin resistance. It's a lot more sensitive than simply looking at glucose to insulin ratio. There are a lot of new medications, like Dr. Awad mentioned, for weight loss, and these medications have unknown side effects on the fetus, so it's not recommended for the patients to conceive while on it. So they should be on birth control pills along with barrier methods. In our office, we've been using Mounjaro, Tirzepatide, and these are injections. You start with low dosage, 2.5 milligrams once a week. The box comes for the whole month, so 2.5 milligrams for the first month. Then I go up to 5 milligrams the second month, and then after that I can either go really high or just to 7.5. What I like most about these medications is that they help the patients lose significant weight. On the average 28 pounds, but I've seen it, patients who use these medications and diet and exercise, we've had patients who lost as much as 58 pounds in 3 months. So these are really, good weight loss medications, and at the same time, they treat insulin resistance. In the past, we used mostly metformin for insulin resistance, and a lot of these patients ovulated, but I really did not see much weight loss on metformin, almost none. We talked about ovulation induction earlier in the lecture, and ovarian drilling. If you ever perform ovarian drilling, you have to mention one of the risks, which is compromised ovarian reserve or decreased ovarian reserve. When Clomid fails for 3 months, or letrozole, we no longer use gonadotropins. It's really not a good idea because of the risk of multiples if we're only transferring a single embryo. And then we use gonadotropins where the patient has 4 or 5 follicles. It's almost like we're working against ourselves, and we're not doing much to lower the risk of multiple pregnancy. The issue with twins, as you all know, is the preeclampsia is much higher, gestational diabetes, and preterm delivery. So twins, 50% of twins deliver preterm. So we really don't want twins, and our goal is for singleton healthy pregnancies. And even the CDC classifies all twins as, they consider only singletons as healthy pregnancies, and twins are not, regardless of whether they delivered at term or not. And twins tend to stay in the hospital longer, even when they deliver at term, and they have more lung immaturity, skeletal deformities, and so on.